So, good morning, everyone. Let me start off with this quote by Robin Sharma that Sorry about that. So, let me start off my presentation with a quote by Robin Sharma, whom we all know. He's a Canadian author and he's the author of one of the best selling books in the world, The Monk Who Sold His Ferrari. So, investing in yourself is the best investment you will ever make. So, we have to invest in our physical health, we have to invest in our mental health, we also have to invest in knowledge because that is what is going to get us forward in the long run. So my topic for today is laparoscopy in pregnancy. Is it a safe option? So the guidelines that I've incorporated in my presentation is from the British Society for Gynecendoscopy. It has also been endorsed by the RCOG and the SAGES. Now laparoscopy has been widely used to diagnose and treat acute and chronic gynecological and general surgical conditions. It has become an acceptable surgical alternative to open surgery. But to date, there has been little clinical guidance pertaining to laparoscopic surgery in pregnancy. So the intended audience for my presentation are the obstetrician and gynecologist in the secondary and tertiary centers, general surgeons and anesthetists. But the important thing to remember is that only laparoscopists who have specialist laparoscopic skills and who can perform complex lap surgeries regularly should undertake laparoscopy in the pregnant women. So the incidence is a little low. It's around 1 in 500 women who require non-obstetrical abdominal surgeries during pregnancy. And the most common non-obstetric surgical emergencies include acute appendicitis and cholelithiasis. So coming to my first video, now this was a primee who conceived after IUI and she was diagnosed to have a heterotopic pregnancy. So heterotopic pregnancy, as we all know, the incidence is more in fertility conceptions. So both the intrauterine pregnancy as well as the one on the tube had a fetal heart and she also had hemoperitoneum, as a result of which we had to take her up for a laparoscopy. So as you can see, the uterus is a gravid uterus. The right tube is normal, the right ovary is also okay, but she has moderate hemoperitoneum and the left tube had a large tubal ectopic which had almost ruptured. The patient was also hemodynamically unstable and hence we had to take her up for a laparoscopy urgently. Now we ended up doing a lap salpingectomy for this patient, but the intrauterine pregnancy continued without any issues because there was absolutely no forms of uterine manipulation involved. So the recommendation for the non-emergency procedures during pregnancy has been to always avoid surgery during the first and the third trimesters. Why? To minimize the spontaneous abortions and the preterm labor. But there has been the gestational age limit which has been recommended is around 26 to 28 weeks. But the recent literature demonstrates that the pregnant patients can undergo laparoscopic surgery safely during any trimester without increasing the risk to the mother and the fetus. So again, the incidence is low. Hormonal changes during pregnancy definitely increases the risk, as in it increases the gallstones, the sludge in pregnancy, and even fertility treatments with GnRH analogs, which involves controlled ovarian stimulation, increases the risk of torsion, because of the hyperstimulated ovaries and the hemorrhagic ovarian cysts, but the absolute numbers are low in pregnancy. Now, without appropriate surgical treatment, appendicitis and cholecystitis can carry specific risk in pregnancy, which includes generalized peritonitis and maternal sepsis, and this results in miscarriage, preterm delivery, and stillbirth. So this was a pregnant woman. She was actually a preemie. At 24 weeks, she presented with acute cholecystitis, and this was not resolved with medical management. We tried medically managing her for up to 2 weeks, but then the pain was not at all decreasing, and we had to take her up for a cholecystectomy. Now, the problem with doing cholecystectomy in pregnancy is the position that the patient has to be put in. You have to put her in a reverse Trendelenburg position. So the steep Trendelenburg and the reverse Trendelenburg both is a little tricky because of the positioning of the pregnant patient and because of the gravid uterus that is present. But in this patient, we involved the gastrosurgeon. The cystic artery and the cystic duct were separated. There was not much of bleeding. Now, retrieval of the specimen in a cholecystectomy is again another difficult part, because you do not know what the contents are. You do not know whether there has been an active infection. You do not want to cause any spillage. So we ended up putting this gallbladder into a endo bag. The endo bag is actually a modified one that was made in the hospital itself, and the specimen was introduced into an endo bag and retrieved through the supraumbilical port. But thankfully, the pregnancy continued uneventfully, and she went in for a normal delivery also at term. So that is the specimen being introduced into the endo bag and the bag being retrieved through the supraumbilical port. So how safe is laparoscopy? Why is that previously we did not do laparoscopy, and why has been a change in the paradigm, or the change in the what has changed in the technique of laparoscopy? One is, what we all have to know is that when you have appropriate surgical equipment and the expertise, laparoscopy should be considered as an alternative approach to laparotomy. It does not increase the risk of stillbirth or fetal malformations. Again, I am not saying that only laparoscopy should be done. It always depends on the expertise of the doctor involved. The decision between the laparoscopy or the route of surgery should be depending on the available expertise, the infrastructure, the background history, the gestation, and the woman's preference. So it is not that it's laparoscopy in all pregnant women. So maternal risk, you have the general laparoscopic surgery risk, which applies in pregnancy as well. We have the gravid uterus, we have the limitations to the visual field and the surgical axis. There is an increased risk of vascular and organ trauma. It can lead to uterine perforations. If there is a uterine perforation, it subsequently increases the chance of uterine rupture, infections, preterm delivery, and lacerations of the fetus and the placenta. So again, the clinician should be aware of the increased risk of bleeding due to the increased vascularity to the uterus and the adnexa, but this risk cannot be quantified. Now, this is similar to a video that Paul sir showed in his last lecture. So this was a pregnant mother. She was actually a preemie who had a delivery 8 months back, and she was diagnosed to have a lower cervical segment pregnancy, as in it was an undiagnosed scar ectopic at 12 weeks of gestation. At 12 weeks, she came to us with spotting. We took her up for a laparoscopy, and this you can see the large fetus being taken out. The couple was counseled, because at 12 weeks when you do a laparoscopy, there is always a risk of the uterus ending up in a hysterectomy. We did a bilateral uterine artery ligation. The blood products were arranged. A consent for hysterectomy was taken, but still this was a fertility preserving surgery because she only had one child and the child was just 8 months old. So we freshened the scars and we ended up suturing the cesarean scar laparoscopically with the help of Vicryl. Now patient was followed up and it's now been 6 months. We've asked her to come back for a follow-up hysteroscopic to make sure there is no niche. So definitely the risk of bleeding is more when you tackle large cesarean scar ectopics in advanced gestation, say 12 weeks, 13 weeks. It's always safer if it is identified before that. But in this case, the identification or the ultrasound missed the cesarean scar ectopic, and it was just diagnosed as a lower segment, and that is a pregnancy which had implanted in the lower uterine segment. The scar ectopic was missed, as a result of which she continued without problems till 12 weeks. But thankfully by 12th week she had spotting, which ended in this laparoscopy. So what about the anesthesia related risk? The obstetric anesthetist should be involved, and aspiration prophylaxis should be administered, and a strategy for the airway management should also be made. General anesthesia and endotracheal intubation are essential, and a use of a laryngeal mask airway is not recommended. Now again, creation of the pneumoperitoneum should be gradual. The pregnant woman should undergo a non-obstetric surgery, and venous thromboembolism prophylaxis should be administered, because pregnant women are at a higher risk, and the administration should be on par with the guidance by the Green Top guidelines. So this was again a primea gravida at 6 weeks of gestation who presented with severe acute onset lower abdominal pain. So the uterus is gravid, and here you can see that the right ovary has been enlarged with a large cyst, and the right ovary had tossed around its pedicle. So the pain was intractable, as a result of which she underwent laparoscopy. So this was actually a hemorrhagic corpus luteal cyst. She had undergone IUI, and she had controlled ovarian hyperstimulation, and the corpus luteal cyst had tossed around its pedicle, causing the severe pain. But in this case, again, the technical difficulty is because corpus luteum is a very friable structure, and each time you try catching hold of it, it keeps on bleeding. So because the pregnancy was only at 6 weeks, and because we had tackled the corpus luteum, we put her on estrogen and progesterone support, just like what we would do for a frozen embryo transfer, and she is now at 25 weeks of gestation. So another thing to remember while doing a general anesthesia or giving a general anesthesia for the lap patient is that the end-tidal carbon dioxide, the EtCO2, should be used as a surrogate marker for the arterial carbon dioxide, and the clinician should also ensure the uteroplacental blood flow by avoiding maternal hypotension. So again, up to what gestation can you perform laparoscopy? Can you perform laparoscopy beyond your second trimester? So again, studies have shown that cholecystectomy and adnexal surgeries have been done up to 34 weeks. But then any surgery in pregnancy is associated with maternal and fetal risk, and non-urgent surgery should be postponed till after pregnancy. So should we monitor the fetal heart before, after, and intraoperatively? No. We can just monitor by ultrasound before and after the surgery to confirm the fetal well-being. If there is a risk for preterm delivery, antenatal corticosteroids and magnesium sulfate for fetal neuroprotection should be administered. Anti-D administration is not deemed necessary. Routine tocolytics have also not been recommended. And if there is maternal sepsis involved, caution needs to be exercised in steroid administration. Now this is a slightly controversial video. So this was a patient at 22 weeks. She was a second gravida. She had a history of preterm labor in the first trimester in her last pregnancy. So for her, we did an encerclage. She was an IVF conception, 39-year-old. We did a vaginal encerclage for her at 12 weeks, and she still ended up having prolapse of her bag of membranes at around 20 weeks. So this is actually a 22-week gravid uterus for which we did a laparoscopic abdominal encerclage. So technically this was a very challenging case because of the size of the uterus, and technically it is very difficult to put the Mercilin tape around this gravid uterus because of the size of the uterus. So what we did was we dissected the space between the ascending and the descending branches of the uterine. We took the Mercilin tape without the needle around the gravid uterus. The needle holder was introduced through the right, an opening was made in the broad ligament, and the Mercilin tape was taken below, and this was all after dissecting the UB fold. So this pregnancy was at 22 weeks, and the reason for the laparoscopy was that she had almost reached fetal viability and the vaginal encerclage had failed. So then we put in the knot as high as possible. For this patient, we did administer her tocolytics because we could see the membranes at the level of the external os. Reducing the membrane again was difficult. We also did a vaginal ultrasound at the same time we were performing this, so that we could see how high the membranes were pushed back in. Now, if you ask me till what age the pregnancy continued, the pregnancy went on for 5 more weeks and she ended up having PPROM at 27 weeks, but we could salvage the baby. So for her, this was important, but is this according to the guideline? No, there is no guideline which tells you that you can do an abdominal encerclage at 22 weeks. There has been a couple of case reports and we have also put this up for publishing. Now, placement of ports. The location of the primary port will depend upon the level of the uterine fundus. Insertion of an orogastric tube for gastric decompression may be helpful when Palmer's point is used for access. So then what about the difference in the intraoperative techniques? You can use the open technique for primary port entry, varus needle, optical trocar, but there has been no evidence in the late trimester. There has been a limited degree of freedom due to the gravid uterus being present. The intra-abdominal pressure should be between 10 to 15 millimeters of mercury. 5 to 10 mm laparoscope with 30 degrees should be preferred. The choice of tissue extraction should be in accordance with the surgeon. Minimize the use of energy sources, and all ports which have more than 10 mm size should have a facial closure. So this is one of my last videos. So this is again a multigravida in whom a lap abdominal encerclage was done, and she ended up delivering 2 children through cesarean, but at the last cesarean, the abdominal encerclage was not removed, and this is the main reason. She came again pregnant and wanted an MTP. We also thought we would remove the abdominal encerclage. The Mercilin tape had burrowed into the bowel, as a result of which we could not see the Mercilin tape, and probably that was the reason why the Mercilin tape could not be retrieved during the second cesarean. So here we involved a colorectal surgeon, and the patient could also feel the Mercilin tape coming out through her anal opening when she was defecating. So these are the problems that occurs when you don't remove the Mercilin tape along with the second cesarean or whenever she's finished planning for her pregnancy. So here the Mercilin tape was retrieved from the bowel. The bowel was sutured. The Mercilin tape is covered in fecal matter, as a result of which the Mercilin tape was put into an endo bag to prevent any sorts of peritonitis. The patient had a prolonged stay in the hospital for around 10 to 14 days, but she recovered well and uneventfully. So again, if you ask me, what do you do if the Mercilin tape burrows into the bowel at the time of cesarean? Do you call in the colorectal surgeon? No, but that has to be documented in your notes that you have not removed the Mercilin tape at the end of the cesarean, because it is always helpful in the long run. So post-operative care, antibiotics should be used if there is an infective process. In the case of elective surgery for adnexal masses, antibiotics are not routinely required. So good analgesia, adequate rehydration, and measures to prevent post-operative nausea and vomiting should be integrated into the maternal post-operative care. Now this is again an old video, so apologies for the clarity. So this was a patient in whom an abdominal encerclage was done, and she went in for PPROM at 20 weeks, as a result of which the knot was placed anterior and we had to do a re-laparoscopy to remove the encerclage. So nowadays when you do an abdominal encerclage, it's always better that you put the knot below, because it can be retrieved without having to take the patient up for a second procedure. You can, if the knot is posterior, you can open the POD and retrieve the knot vaginally. So in this patient, we did not do anything further for her. We removed the encerclage and then she was lost to follow-up. So again, this is another video of a gravid uterus. Again, the woman had a large adnexal cyst. She came with torsion. So here the cyst was at least up to 24 weeks in size. So when you have a cyst at 24 weeks or at the level of umbilicus, it is technically challenging because you find it difficult to introduce the ports. You are not sure what you're going to rupture, and there is absolutely no forms of uterine manipulation that can be done. So again, here we drained the cyst, and the port entry was using a Palmer's point entry. We drained the cyst. The cyst was excised using harmonic scalpel. And the remaining of the ovary was sutured. So especially in where you have a fertility setup, where you use a lot of gonadotrophins, where you have multiple follicles developing, there is always an increased incidence of ovarian cyst, hemorrhagic cyst, and these can lead to torsion. So when a patient in her first trimester comes to you with severe abdominal pain, it need not be any non-obstetric cause. The first thing that we have to rule out is a heterotopic pregnancy or an ovarian cyst. Now to conclude, most adnexal masses in pregnancy can be expectantly managed. The best time to perform the surgery is in the second trimester. Use a nasogastric tube to decompress the stomach. Intermittent pneumatic pressure of the lower limbs for thromboprophylaxis. Use a left lateral recumbent position. Avoid any forms of uterine manipulation. And because of the gravid uterus, the primary trocar should be inserted at least 5 centimeters above the upper part of the uterus. You can always use a Palmer's point entry as well. There has been no clear benefits of tocolytic agents before, during, and after the surgery. If there is a risk of imminent preterm labor, use tocolysis. If it's a pre-viable fetus, a simple ultrasound examination proves the cardiac activity before and after the surgery. It is unclear whether continuous fetal heart monitoring is required when operating on a woman who is above 24 weeks of gestation. In addition to that, when you have a pneumoperitoneum, monitoring the fetal heart intraoperatively makes it more technically challenging. Now let me end with a quote by Rumi, that yesterday I was clever, so I wanted to change the world. But today I'm wise, so I'm changing myself. Thank you.